Hi, it's the nursing professor here. Today we want to talk about bowel elimination. Last week we talked about urinary elimination, and quite similar is bowel elimination, and where it is the process our bodies take in order to eliminate waste. Quick snapshot of anatomy starts at the mouth. GI system starts at the mouth. We have to assess the dentition of a person, make sure they were able to chew, swallow their food, goes on down, small intestine, large intestine, then out of the rectum. All right, frequently it's called defecation or elimination of feces or poop or any of those types of things, but it's all the same thing. It's waste that must be eliminated from the body. All right, so there are factors that do affect this bowel elimination, and it includes developmental stage. We know as we have little ones, infants, toddlers, they're unable to really control when they need to have a bowel movement. Also, privacy is huge. Privacy in certain cultures can be very impactful on bowel elimination. We don't have them very often anymore, but we used to have a lot of semi-private rooms. We used to even have 4 people in a room when I first started out in nursing. And you can only imagine how much that impeded a person's ability to have some privacy and go to the bathroom without being interrupted. Medications, anesthesia, surgery, and different procedures also impact the bowels. It typically slows them down. All right. Pregnancy, different pathological conditions like various types of cancers can also have an impact on the bowel elimination. So one of the ways we actually treat pathological conditions with bowel elimination is we do what's called bowel diversions. And this is where the disease portion of the colon is actually removed. Could be small intestine, large intestines. It's actually removed and then anastomosed or put back together. Frequently, that anastomosis can end up with just that person have a shortened colon and they still can poop out of their rectum. But sometimes that they're unable to do that because such a large portion of the diseased colon had to be removed, and that person would have what's called an ostomy. An ostomy is an opening on the abdomen where the stool will actually come out. Depending on the location of the surgery, the surgical cut. Like if it's in small intestine, it's called an ileostomy. That stool is going to be pretty watery, and that person may have problems with absorption, not being able to retain enough fluid, because we know that that's where the process happens in our small intestine. If that person actually has a cut in the large intestine, especially as it moves further over to the left side of the abdomen, then bowel typically is formed. And so it'll go into a pouch. That person is taught how to empty it, how to manage the skincare around there, because we can only imagine how irritating GI gastric juices can be. All right, because so we never want gastric juices to be on our skin because it will really make it very irritating. So now let's go to the nursing process and how that is impacted with bowel elimination. All right, so first we're going to get a focused nursing history. We're going to get a baseline. We ask that person how frequently they go to the bathroom. When do they normally go? Is it first thing in the morning? Is it last thing at night? Is it right after meals? We're getting some sort of baseline for that person, and that's important. We also do a physical assessment, and you can use your stethoscope and actually listen for bowel sounds. You'll hear like these gurgling type noises to determine if bowel sounds are sluggish, or if they are hyperactive, or if they are totally absent, which sometimes does happen with various obstructions. There are other diagnostic tests that we can do, including a flat plate x-ray, where a person actually has radiography that determines if there's, say, impaction or constipation, a lot of stool sitting in the colon. You also, and this is the best way of doing it, is direct visualization of the colon, where you actually take a scope, and that scope is actually inserted into the rectum. It will go up into the colon. If it goes into the colon, it's called a colonoscopy. If it goes into the sigmoid, it's called a sigmoidoscopy. And so it visualizes internally what's happening in the colon. If it sees any abnormal tissues, it can get tissue samples. It can actually remove polyps. And so it really is a very good, pretty accurate procedure. Frequently, people they don't like it and they'll skip it because of the preparation. It's very important that we make sure our patients understand that they need to take all of the preparation, which is basically a laxative, in order to clear the colon so that the internal structure of the colon can be visualized. If it's still packed with stool, then we're wasting everybody's time, because the surgeon will not be able to see within the colon if it is full of stool. Another test that we can use is Cologuard. You might have seen the little commercials with the man with the box and he's moving all around. Well, this particular test actually looks at the DNA in the stool, and it works well for people who have a low risk of colon cancer. You know, no one in their family is known to have it. And so you take a stool sample, you put it in a certain medium, and you mail it back in, and they'll send you your results to determine if it is normal or not, and if further testing is needed. Most frequently, and one of the more simple tests that we have is called a FIT kit, FIT test, fecal occult blood, any of that. And that's when you get these little cards. They'll have two small windows in it. You take a sample of stool from two areas of your bowel movement, you put it on the card, you close it up, put your name on it, you mail it back in. And the lab actually processes it to determine if there's blood in your stool or not. If there's blood in your stool, again, it would require you to go for further testing. Now, a couple of things that can make a fecal occult blood test a false positive is a person who had a lot of red meat prior to getting the sample, a person who took a lot of vitamin C. Yep, vitamin C can give you a false positive. And of course, a woman who's menstruating. So if any of those things are the case, you want to wait before you actually do that test to help avoid a false positive. Then you come to your nursing diagnosis. It's going to depend on the symptoms, of course. It could be alteration in bowel elimination related to constipation or related to diarrhea, or slow GI motility that could happen from anesthesia, toileting self-care for those people who have mobility problems. All right. And so we got our assessment, we got our nursing diagnosis. Our plan is going to depend on what we have been able to assess is wrong with that person. But some of the interventions that we might include is making sure a person has adequate fluid intake. They have adequate fiber in their diet, like fresh fruits and vegetables, beans, things like that. Exercise. Exercise is really important. We're helping the motility of the GI tract. Okay, now frequently some of your older patients are going to be people who take a laxative, whether or not they need it or not. They'll take it daily. They'll say, oh, honey, I take milk of magnesia every day. That's what they've been raised on. You are not going to be able to change them. But it is important to make sure that them and their family understand the risk that comes with that, especially dehydration if a person is taking laxatives every day. All right. Constipation is miserable, but we want to make sure that we avoid any type of impaction. And that's when the stool is really hard at the opening of the rectum, and it has to be broken in two before you actually get to the stool to help the person go to the bathroom. This is not a procedure you should delegate. This is a procedure that the registered nurse or licensed nurse should actually do. If a person has diarrhea, you need to know the cause of it. If it is from eating something bad, you want that to come out. So you want to be careful too of making sure people are educated not to take those anti-diarrhea medications because they're having loose stools, unless they are directed by their physicians. We also want to make sure they have privacy, that they feel comfortable, and so that a person can go to the bathroom. If a person is constipated, we can do things like give them laxatives, enemas, things like that to help them go to the bathroom. But colon cancer is on the rise, especially in younger people. It's very important that we take our time to make sure our patients are educated such that we can avoid some of those problems. I hope this helps. Please like and share, and I'll see you next video. Bye for now.